Madeline Lee Sosi showed up at the Indian Health Services Hospital in Gallup, New Mexico in April 2020, feeling poorly and having trouble breathing. When her coronavirus test came back, she was given a prescription for an inhaler, an oxygen tank, and orders to go home and rest. 3 days later, Miss Tosi, a 40-year-old school secretary, was back, this time in dire condition. But the hospital was ill-equipped to handle severe coronavirus cases. She was transferred 2 hours away to a hospital in Albuquerque, where she died alone. It is this story, and many like it, that inspired us to look at the critical issues affecting rural health, particularly on the Navajo Nation. Today, we will look at what drives these disparities, give potential solutions, and make some recommendations to improve health outcomes within the Navajo Nation. Let's take a look at the Navajo population. The Navajo Reservation was formed in 1868 under a federal treaty, which also put the government in charge of healthcare for the Navajo people. Today, more than 200,000 Navajos live on the Navajo Reservation. It is the largest tribe in the U.S., covering 13 counties in 3 states. It makes up 12.5% of the Indian Health Services population. Around 50% of all Navajos live below the federal poverty level. Unemployment is nearly 56%, and the per capita income is 1/3 of other U.S. residents. Yet the government spends more than twice the amount of health care for federal prisoners than they do the Native American population. This has made many begin to wonder if the Navajo Nation itself is better equipped to handle their own health care. These facts put the Navajo people at extreme disadvantage for equitable health care on their own, but the story, sadly, gets worse. Briefly, health disparities on the Navajo Nation stem from poor access, economics, social challenges, and poor chronic health. Today, we will focus on the 2 largest contributors, access and chronic health. Federal funding only meets 54% of health needs for a population that has a 31% higher mortality rate than the rest of the U.S., with soaring rates of diabetes, obesity, and mental illness. Access is the first critical gap to quality health outcomes. The Navajo Nation is at a substantial disadvantage over the rest of the U.S. population when it comes to access. It is rural and isolated. Many live up to 3 hours from fresh food and a grocery store. More than 3/4 of the roads are unpaved. More than 1/2 lack phone and internet access. Nearly 1/3 lack complete kitchens, and 40% of the population lacks running water. Water, already a scarce resource, became a big challenge with the COVID pandemic. Faced with clean drinking water or hand washing, the Navajo Nation faced a crisis most of the rest of us in the United States that only occurred in third world countries. If people can make it to a clinic or a hospital, they face yet more access barriers. Most health facilities on the reservation are obsolete, with facilities being nearly half a century old, and the provider vacancy rate for some positions is up to 40%, the largest vacancy rate in the Indian Health Services. Chad is going to dive deeper into infrastructure, resulting access issues, and possible solutions.
Thanks, Sarah. That was a great overview of some of the challenges that the Navajo people face with health disparities. I'm going to talk a little bit more about some of the infrastructure barriers that they face. So the Navajo Area Indian Health Service, or the NAIHS, provides healthcare services for nearly 250,000 American Indians. The area that they cover is 25,000 square miles, which is roughly the size of West Virginia. They have approximately 4 hospitals with additional 8 health centers to serve this entire population. Within this area, they have roughly 222 inpatient beds, which comes to a percentage of about 1 bed for every 1,000 American Indians, which is about half the normal U.S. average. So as far as some solutions to these infrastructure problems, obviously they're not going to be solved overnight, but some ideas that we have would be to construct micro clinics closer to the population, and these clinics would be set up to have telehealth connectivity and staffed by maybe a pharmacist or a PA or an NP along with a nurse and some other minimal staff to basically help patients get the care they need remotely, right? So they can come to the clinic, and if they need more care than what the person there can provide, they can then easily hook the patient up remotely to a more specialized provider. Another option would be to create mobile clinics from RVs or vans that can be driven on dirt roads to reach these patients, and they can set up time, 1 day a month for each area that they can go out to and provide, health and nutritional advice, do small, simple procedures, provide or dispense medications or other healthy food or something like that to kind of help get this care to the patients. Another thing is to work with county, state, federal government to help improve the roads and basic infrastructure, so that'd be increasing broadband coverage, electricity, running water, some of these people and sewage stuff, just to try and help get them some of these basic necessities of life. Not only are there infrastructure barriers, but also healthcare worker barriers, right? Shortages of healthcare workers, which is going to be a bigger problem as we go along. This chart basically shows kind of the disparities that exist between urban, rural, and IHS providers. So you can see, for example, pharmacists. There are about 8.8 pharmacists for every 10,000 people living in urban centers. That number drops to 6.1 in rural and 3.1 with IHS. Similar drops along the board with physicians from 31 to 12 down to 3. RNs are the most plentiful resource in IHS and in the other areas, but still they only have 9.3, which is about 10% of what other areas see. So some solutions to these problems, support the current legislation that is being out there. There's this one called IHS Tax Fairness Act, which looks to make permanently tax-free any monies that patients or people receive for scholarships or, tuition forgiveness for working in IHS, and also the Improving Access to Indian Health Services Act, which allows people to bill Medicaid, providers to bill Medicaid for services provided outside of an IHS facility. This would definitely allow our mobile clinics to function. Obviously, we want to improve access to telehealth services with these micro hospitals or clinics, and want to improve broadband service within the Navajo Nation so that they can get telehealth on their own. Maximize that current workforce and allow them to work at the top of their license or abilities. We want to work with the health colleges to provide tuition-free or significantly reduced schooling for Native American students.
Now moving to look more at some specific health disparities for chronic health conditions. We're going to focus specifically on diabetes and then mental health and substance use. So in the Navajo Nation, approximately 50% of all adults have diabetes or prediabetes, and this higher prevalence is causing diabetes to be the 4th leading cause of death among the Navajo Nation. Patients in Navajo Nation who have diabetes also have twice the mortality rate compared to the rest of the U.S. population with diabetes. Moving to focus on mental health, the suicide rate in the Navajo Nation is 20% higher than that of the U.S. white population across all age groups. Then looking specifically at teens and young adults, suicide is 4 times greater in older teen girls compared to their white counterparts, as well as it is the 1st and 2nd leading cause of death among children and teens in the Navajo Nation. The Navajo Nation children and teens group also has the highest rate of major depressive episodes when compared to other groups by race and ethnicity. Focusing on substance use, the rate of mental illness and substance use at the same time is 3 times higher in the Navajo Nation compared to the general population. And then focusing on alcohol and drug use in teens, the age of initiation of drug and alcohol use is earlier or younger in the teen population in the Navajo Nation compared to the rest of the U.S. population, and then there's overall a higher prevalence. So what are some possible solutions to address these chronic health disparities in the Navajo Nation? First, for diabetes care, in 2010, an interesting project titled the Community Outreach and Patient Empowerment or COPE project was launched in collaboration with the Navajo Nation Community Health Representatives Program in order to reach out to individuals living with diabetes and improve their health outcomes. Specifically, the project focused on increasing referrals to the CHR program for high-risk patients, supporting the CHRs through training and standardized materials, as well as strengthening the coordination between CHRs and clinic-based providers such as primary care providers. Overall, this program, the COPE program, showed a clinically significant reduction in a clinical marker of diabetes management, their A1C, for patients at both 12 and 24 months. The program also found a clinically relevant decrease in cholesterol levels at 24 months as well. These promising results could be further expanded to collaborate with the CHR program to include more screening without referrals required by a primary care provider. So reaching out into the community to identify patients who are not already established with a primary care provider and bringing them into the healthcare system through these community health representatives. Increased access to healthier food options would also go a long way in improving management of diabetes for these patients. Moving on to mental health and substance use in the Navajo Nation, some strategies or possible solutions would be to increase counseling resources in schools, increase access to telehealth counseling, which was mentioned by Chad earlier in the infrastructure section, as well as increasing training for existing primary care providers on how to provide culturally sensitive counseling and treatment for mental health and substance use conditions. Finally, one of the best possible solutions would be to expand these community health representatives that were shown to be so successful with diabetes management and expanding their scope of services to provide mental health checks, counseling, and access to medications.
Before we dive into our final recommendation, we do just want to acknowledge that any plan that we propose or implement within the Navajo Nation will need input, leadership, and buy-in from the Navajo Nation itself. As outsiders to this community, there are many things within the culture that we do not understand and the implications that they may have on how these things are received or perceived by that community. Having that insider knowledge will be huge as we implement these plans. So, as far as what our actual recommendation for how to address some of these barriers to access and health disparities that exist within the Navajo Nation, we are recommending a two-pronged approach. First of which is establishing a network of micro-hospitals, and the second is to establish a fleet of mobile clinics, which we'll dive into a little bit later. All right, so more on these micro-hospitals. The intent here is to overcome the barrier to access. We know that travel throughout this region, the roads are not great. There's a lot of barriers for someone to make it all the way to one of these large medical campuses. Our plan is to decentralize those large medical campuses into several smaller strategically placed micro hospitals. As we've mentioned earlier, we would like to expand the scope of practice of some of our APPs, the physician assistants, nurse practitioners, or pharmacists, so that they could staff and run these micro hospitals. These micro hospitals would have the capabilities and equipment to treat acute illnesses and stabilize patients, and if need be, escalate the care to a larger medical facility if they don't have the resources. And then a big piece of this is enabling these clinics, giving them access to telehealth services. So this would allow them, to, if at all possible, to remotely contact a higher level provider to get their assessment, diagnosis, and hopefully prescribe care for these patients without needing to transport them to one of the larger medical clinics. Okay, so our mobile clinics. The intent behind these is, again, to expand the impact that we can have on this large geographic region instead of keeping things centralized, even at these several micro hospitals that we're wanting to establish. This really delivers the care to the communities. There's a rotation set up of where these clinics will be on certain days so that the community as a whole can kind of know when to expect and when they're going to be able to set up their appointments. Our plan is that each micro hospital will have a fleet of, about 3 mobile clinics that kind of serve the area around those micro hospitals. Our plan is that these would be staffed with some lower level providers, so a nurse, a pharmacy tech, an MA. They would have the capabilities to perform point of care testing, so hemoglobin A1C, blood glucose, really geared towards diabetes, diagnosis and management, and some other testing there as well. These mobile clinics would also be enabled with mobile hotspots to allow telehealth connectivity. So the nurse or MA identifies an issue that needs to be escalated. They're able to telehealth in another APP back at the micro hospital, explain what's going on, have an appointment right there with that provider to get that issue escalated and taken care of, and a plan established. The plan is also that mental health professionals could be accessed through this telehealth connectivity with these mobile clinics. Appointments could be made uh, for patients out in the community to meet with a mental health professional without needing to travel all the way to a clinic. It could happen right there within their own community. The last piece of these mobile clinics that we want to implement is a mobile food pantry. We know that access to fresh food from a grocery store is a challenge. There's only 13 grocery stores in the whole expanse of the Navajo Nation. Being able to deliver that food directly into these communities on a routine basis, where they're able to couple that with education on nutrition and diet and exercise, would be huge in bringing that knowledge to the people and providing them resources to make real change in their own lives. Okay, so that is our plan in a nutshell. If you have any questions, please feel free to reach out to our group, and we will do our best to answer those questions for you. Thank you.